Hello and welcome to Acadicus. In today's simulation scenario, we'll go over the proper setup for central venous catheter insertion. On my left, we've set up what would be your table for readiness, and on the right, I've set up a table with a full display of all the different equipment that you would see when preparing for central venous catheter insertion. As with any of the Acadicus tutorials, you'll be able to first watch a full video of the simulation, where I kind of walk you through all the different pieces of equipment and all the proper setup. And then, as with any Acadicus video, you'll be able to then walk through the scenario yourself, picking up all the assets, handling them, and using them as you see fit. And then in the premium level of Acadicus, you can get an unlock code that will allow you to manipulate the environment itself, adding and removing pieces of equipment, moving different pieces of equipment around in the room to create your own scenarios. So today, we'll get started with central venous catheter insertion preparation. So my name is Nick Slamon. I'm a pediatric intensivist at the DuPont Hospital for Children in Wilmington, and I'll take you through first the setup. So as you can see here, we have a sealed central venous catheter kit, and this tab on the end allows it to be sealed and sterile. And what we would do would be to rip this tab open and expose the inner surface of the kit, and what we would see would be a blue sterile covering. That blue sterile covering without a gloved hand can be picked up and lifted out, and then using again your clean but not sterilely gloved hands, you would unwrap this kit, and it would then look like what you see here. So in the kit itself, you'll have various pieces of equipment that we'll go over on our sterile table. But what most people will do is take that blue dressing that is kind of wrapped and covering the sterile kit and unfold it piece by piece so that all the sterile pieces that you've then soiled with your bare hands are underneath, and everything that's in the kit is still sterile. Next, you'll take a pair of gloves. I happen to wear a 7.5 glove, and you unwrap them, and when unwrapped, they'll appear like this on the table. When you glove, the gloves have an inner surface that'll be on your skin. You're able to pick that up with your bare hand, and then using your second hand, insert your hand into the glove. Now that your right hand is sterile, you can touch any part of the second glove and help put that on your left hand, and then you'll have sterile gloves on. We'll save that for later because we'd like to put on our hat, our mask, and our gown first, and then glove. But some people, in order to set up a table for themselves to work on, will say, I'm not going to put on my gown yet. I just want to have a pair of gloves and then have an extra second set of gloves for when they're ready to actually do the procedure. The other two pieces of equipment that are important to talk about here is we have our biopatch and our chlorhexidine swab. So these are often sealed, again, in sterile fashion. You can open them yourself and dump them on your table when your sterile drape is already set up, or you can have a second assistant, your respiratory therapist, your nurse, resident, or fellow, open them for you, and when you're fully sterile with gloves on, you can kind of take them out of the package. So now let's move on to the sterile table. So assuming that I've kind of set up this worktop ahead of time in sterile fashion, spreading out the sterile sheet, everything that I put on the table is sterile. I have to touch it with gloved hands. Can't touch it with bare hands and then touch it to the patient, as it'll contaminate them and lead to bacterial increase when you put your central line in. So a couple of the things that I will set up first and get ready first. So here I have my sterile gown, a face shield, and a hat. And often what I'll do is, at DuPont, we have what's called a sterile pack. So in addition to the central venous line kit, there's a plastic bag that's been prepared in sterile holding downstairs in the basement. It contains a hat, a mask, a gown, a drape, and extra drapes that you could use to spread out as your sterile surface. So you can open that, again, just like we did with the kit with bare hands, slide that out, it comes in a sterile wrap, you unwrap it and unfold it so that all the contaminated surfaces are now underneath, and then you can put gloves on and touch everything that's inside in a sterile fashion without contaminating it. So what we'll first do is apply our hat, and we just kind of stretch out. You can have the surgical cap, or what this is called is a bouffant cap. Looks almost like what a chef would wear. So you put your hat on first. You then adjust your mask. The mask has a metal rim inside of it that you can mold to your face so that you make sure you have a good seal as you can breathe. But you also, if you wear glasses like I do, you don't want to fog up your glasses with every breath. So you kind of mold that metal piece across the nose right here so that it will, keep your breath from going upwards and fogging your glasses. So hat first, then mask, then gown. So the gown is folded just like you see here, and it can be held here. There are two little pockets where you can put your hands in that'll become your sleeves. You kind of fold out to the side and snap down, and the gown just kind of unfolds. Put your arms in the sleeves. There's a Velcro tie that goes around the back of the neck. You're kind of taught when doing sterile procedure, you don't want to reach up and behind yourself. That would contaminate your hands. So I often just put my hands into the sleeves. I've already got my hat on. I've already got my mask on. And then I have an assistant come and do the Velcro tie that's up at the neck. And then there's a little tie at the back as well that I often leave open. But everything in front of you, your sleeves, your chest surface, your abdominal surface of the gown is all considered sterile at that point. So once I've got my hat, mask, and gown on, I'll go on and put my gloves on in the method that I described. My bare hands are clean, but I can reach into the right glove, pull that on. Any surface that I touch is on the inside of my sleeve at that point, so it doesn't matter. The outside is still sterile. Then with a right gloved hand that is completely sterile and clean, I can pick up the left glove and pull that on at that point. So other important pieces to go over on our sterile tray at this point. So here's our chlorhexidine wash. So the stick is manufactured in a way that we have these two wings that you pinch with your thumb and your index finger, and you'll hear a crack. You shake up the chlorhexidine stick, and that delivers the chlorhexidine distally down to the foam. You're supposed to start at the area that you want to sterilize. So in children, we often look at the internal jugular as our #1 site, the femoral in the groin as our #2 site, and the subclavian as kind of our last resort, highest risk site. But you're going to start once the liquid is coming out of the foam, scrubbing in a circular direction, getting further and further out from the site, and never dragging back into the site at that point. You really want to make sure that you're not recontaminating the area. So start at the site where you want to put your needle, scrub circularly, get a little bigger, make your circles a little bigger, scrub outward along the neck, midline, almost all the way down to the shoulder. And then again, do not hit the shoulder and drag back into your sterile area. Start centrally, move outward. Some other pieces of equipment that we have that often come in the kit. So sterile gauze is important to have. These procedures can have a lot of bleeding. So you do want to have something that you can cover the bleeding and hold pressure with. At the end of the case, we're going to have a sterile dressing that has a notch. The notch will be able to fit where your catheter comes out so that you'll have your access to your 3 lumens. As we mentioned earlier, we have our biopatch. The biopatch is a small antibiotic impregnated disc. The biopatch will go directly over the catheter insertion site, and then the biopatch itself will get covered by the sterile dressing, like so. So at this point, let me move around to this side of the table and have a couple different things to go over. So within the kit, you usually have several pieces of equipment. You'll have a blade, and the blade is used for 2 different pieces of this procedure. So after needle insertion, you will want to insert both a dilator and a catheter, and we'll go over those in a few minutes. The skin site often resists the insertion of the catheter. So the scalpel or the blade is used to make a little bit of a nick in the skin, a little cut in the skin, not trying to cut the vessel, but to make a nick in the skin so that the catheter plastic can pass easier as you insert it. It's often held like a pencil, as you see here, with the blade up, and you cut up and away from yourself so that you don't cut the catheter, you don't cut the wire. And again, we're not trying to cut the vessel, we're just trying to cut the skin itself. This is the catheter. The catheter that we show here is a triple lumen central venous catheter. In pediatric patients, we'll measure from the site of needle insertion to the middle of the chest, which would approximate the SVC right atrial junction. So based on the length, in most pediatric patients, we'll have a catheter somewhere between 5 centimeters, 8 centimeters, or 12 centimeters in length. With a bigger teenage adult patient, we may have something that's as long as 21 centimeters, a long catheter. Now, in terms of the size of the catheter, the diameter, the French measurement of the catheter, most of our pediatric catheters are either 4 French, which are usually double lumen catheters, 5 French, which are triple, and then our bigger pediatric patients, the 7 French is the biggest, widest diameter catheter. So when wanting to push fluids quickly, shorter and fatter catheters are better. As you can see, this catheter is fairly long and skinny, so there might be some resistance to pushing fluid. But the purpose of a central venous catheter is that you can deliver high danger, high problem medications, chemotherapy, vasopressors, things that could damage peripheral veins easily. You can withdraw blood from the catheter to send for various levels of blood tests at intervals without having to stick the patient. So there's a lot of advantages to having a central venous catheter. The catheter itself, as you can see, has these 3 lumens. And before you do the procedure, while you're getting set up, you'll plug in your syringe to each one of those caps, 1, 2, and 3, and you'll flush the catheter until water comes out the other side, assuring that all the air bubbles have been removed. We don't want to give an air embolism to the patient. So if this line, imagine, was full of air, the first time you put it in and you hook a syringe up to it and you push a big bolus of air, that could give the patient a pulmonary embolus. So we don't want to do that. The other thing that you can see is that 2 of these catheters are capped with these green caps. One is capped with a blue cap. So the blue cap is a one-way valve, essentially. It's a pressure valve. So it does not allow blood from the patient to back up into the catheter. You can access the one-way valve, break the seal, and then withdraw blood from it, and then you always have to flush the catheter back through. So all 3 of these lumens should be capped with blue caps, except the central port. The central port is left uncapped after the flushing procedure and clamped because you want to get your wire to come out that central catheter, and I'll describe that in a second. So shown here is the guide wire. So again, let's describe this procedure piece by piece. I'm going to leave this guide wire hanging here. The kit often has 2 needles. I have one on my field and one here in my hand. The needle is held similar to the way my hand is holding it here. You need to have back pressure on the syringe because as you enter the vessel, you want to have a rush of blood fill your syringe to let you know where you are. And often we have ultrasound guidance, and I have an ultrasound machine on the other side of the room. I'll talk about that later. The ultrasound machine is also kind of draped in a sterile fashion with a sleeve that would be on this table. I would open that sleeve, have an assistant put the ultrasound probe in it, and then they would pull the sleeve away from me with some ultrasound gel in there and some ultrasound gel on the patient's skin. So with my left hand, I would get an ultrasound picture of the patient's vessel. With my right hand holding back pressure on the needle, I would enter the vein, get a flush of blood. I would grip the needle and twist the syringe off gently, and then I would put the syringe down, and using my guide wire, I would feed this wire in through the needle into the patient's vein, into the patient's heart, theoretically. Now, as you can see, the wires as they come out of the kit have a J-tip, and they have this guide, this blue dark guide on it. You slide the guide forward and you straighten out the J-tip. The J-tip is a protection for the patient so that when it enters their blood vessel, it's not a sharp point, it's a soft semicircle. Some wires are softer and floppier and don't have a J-tip. They're called a nitrex or nitinol wire. I use those in small patients where their vessels are smaller and they may have a lot of twists and turns. Now, a couple things in adult medicine versus pediatrics. So this guide wire is designed to have this area where your thumb can rub across it and advance the wire. It's meant to stay in this circular sleeve. In pediatric patients, the wire is often tiny. The thumb guide is not all that useful. So we will often take our wire out of the sleeve, leave the straightening tip for the J wire on the tip of it, and load the wire, so to speak, straighten out that J tip, enter it into the needle as I described, and push the wire into the patient while I have a nurse or a resident looking at the monitor to see if there's any ectopic beats. So in a sick pediatric patient, or any sick patient, the wire can be an irritant to the right atrium and cause a arrhythmia that can become very dangerous. If it gets into the ventricle, can be even more dangerous and cause a ventricular arrhythmia. So as I'm feeding that wire, I want to make sure someone's looking at the monitor and see if there's any PVCs or ectopy. And at the same time I'm feeding the wire, I want to have a certain feel. So pediatric critical care physicians usually describe it as feeling like hot knife through butter. It feels like butter. The wire should go very smoothly into the needle. There should be no resistance at all. It should feel very, very easy to push the wire into the patient. So the needle's in the patient's neck. The wire is now in the patient's neck. What do we do next? So the next step is to pull that needle out of the patient's neck. Now we just have a wire. What do we do with that? Well, as I described earlier, I'm going to make that skin nick up and away from the wire to help dilate the skin. And then I'm going to use this piece of equipment, which is a dilator. So the dilator will go over the wire will come out of the back of the dilator, and then I will push the dilator into the patient's skin. Now there is a danger if you hold it all the way back here by the hub that you can bend the dilator and bend the wire. So I often tell my residents, make a good skin nick, hold the dilator right down here at the tip with your thumb and first finger, and then in a backward and forth screwing motion, push the dilator into the patient until it's up to the hub. Now, that will dilate that skin track all the way down to the blood vessel, and it'll make it much easier for that central venous catheter to go. Remember that you never put the catheter or the dilator into the patient without having plenty of wire coming out the backside of that instrument. You always have to control the wire. You don't want the wire to get pushed into the patient and disappear. Then it has to be retrieved by cardiac surgery, which is no fun for anyone. So we've made our skin nick. We've dilated our track. Our wire is still hanging out of the patient. After you dilate, you can expect that there's going to be some bleeding, so you want to have your gauze right nearby because there's going to be a decent amount of bleeding. And then you're ready to load your central venous catheter. Now remember, that wire is going to go in the tip of the catheter. There is plenty more wire inside and outside of the patient than the entire length of the central venous catheter. So the tip of this catheter does not disappear into the patient's neck until we have wire coming out the central lumen. So again, that's why we don't want that central lumen to have a cap on it. We want that one to be open and unclamped so the wire can come out. We grab the wire with our offhand, and then with our right hand, we would insert the catheter into the patient all the way up to this hub. Once the catheter is in the patient, we can pick up our ultrasound again, and we can confirm with ultrasound view that the catheter is in the vein. Very easy to see it as a shadow entering the center of the internal jugular vein. Then again, we want to take our syringes, and as a double check, we're going to put a cap on that last lumen. We're going to draw blood out of the catheter, and then we're going to flush that central lumen, making sure we do not flush any air into the patient, get all the air bubbles up into the syringe, and then flush. We're going to repeat the same maneuver with our other syringes on our other two lumens. Draw blood, make sure it's got blood return, flush the line clean, make sure you don't inject any air bubbles. The last step in this procedure is going to be to secure the catheter. So hopefully you can see it in this video, but the catheter has two wings and a central piece across this hub. We're going to use suture, and I like to use 3/0 silk. This packet rips open. There's a curved needle, and with my needle driver, I'll grab the tip of that curved needle, and I'm going to go in the skin and come up through one of these wings. I'm going to do that on each side, and I'm going to put a third stitch under the catheter and right across this little notch here. So the catheter is secured 1, 2, and 3 places. The third is somewhat controversial. People say, well, I don't want to do too many needles in the patient. That could break sterility and cause an increased risk of a catheter-related bloodstream infection. I've seen plenty of central venous catheters that even though the wings are secured, the catheter itself kind of knuckles out of the patient. So putting this third stitch across, I think, is very important. So one here, and then a stitch underneath, and I'm going to tip to tail, which is a technique used by pediatric patients or pediatric doctors when they suture. I'm going to grab the tip of the string and pull it through to the tail. So again, once my catheter is secured with suture, it's been flushed, it's been ultrasound checked, I'm going to pick up my biopatch and my tegaderm, and I will secure the line from bacterial infection. The last piece to talk about is that I do have some sharps. So I have a blade, I have needles. All of those should be secured in a way that's safe for you and for the other people in the room. Remember, you have residents, fellows, and nurses as your assistant. So here on my table, I have a little styrofoam safety device that comes in your kit. The needle is inserted into the styrofoam and is left there, and then the whole styrofoam needle holder can be thrown into the trash, the red sharps container. So one more thing I'd like to go over while we're here talking about central venous catheter insertion is how the room is set up. So you've seen how my tray is set up, and I often will bring the tray in to the left side of me so that I can just turn and reach for equipment. I want the bed height to be to my level so I don't have to bend and stoop to put the central venous catheter in. I want the patient to be at the head of the bed. And again, as we've talked about in the past with endotracheal intubation, a shoulder roll under the patient, a blanket, a rolled up towel that gets their head extended into a sniffing position and turned to the side so I can expose the jugular vein will get me the best access to the patient. And again, I'm going to sterilize that area with my chlorhexidine. I'm going to drape the patient, which we didn't talk about too much, but the drape which I have over on my sterile setup has a hole in the center of it. So the drape, after the patient is sterile and their head is turned, is stuck. It has a little bit of an adhesive right on the neck, and then it unfolds in a very certain way that has directions, instructions on the drape. So you'll see a part that's marked top or head, you'll see a part that's marked feet, but basically the drape is unfolded with a long end to cover the chest, legs, and feet, a short end that comes up and covers the head. It folds out to the side, so the arms and the entire bed are covered. And really, just like I've made a sterile setup over here for my equipment, the entire bed will be a sterile setup. And I can put equipment on top of the patient if I need to. The last thing to talk about is our ultrasound machine. So our ultrasound machine, you can see, is over here on my right. A various number of different ultrasound probes. We usually will use the first one, the linear probe, and a conductive jelly, otherwise you won't get a picture. So they're going to coat the top of that with jelly. I'm going to have in my left hand my plastic bag, essentially sterile sleeve, because again, this ultrasound has a long cord. So they're going to hand me that probe by putting it in the bag. I won't touch it because my hand is gloved and sterile. They'll put it in the bag for me. Then they will take the edge of that sterile sleeve and they'll pull it the entire length of the cord of the ultrasound, and I can just lay it across my sterile surface. Remember, this entire bed is covered with a blue sterile gown or sterile drape at this point, and I can lay my sterile ultrasound. I'll be able to pick it up with my left hand. I'll be able to insert my needle with my right hand. So all the equipment that you need to mock up and walk through the preparation of central venous line insertion is here in Acadicus. And again, you can watch this video as many times as you like to walk through the steps. And then as a second stage, you can walk through the simulated environment yourself, handling all the equipment, doing everything that I did, getting a feel for where things are, what they should feel like. And then in the premium edition of Acadicus, if you want to make the room your own, I don't want that piece of equipment. I want to add a different piece of equipment. This doesn't look like my PICU. I work in an emergency room. I want an emergency room setting. You can do all those things as well here in Acadicus.